evening, everyone. Welcome for joining us tonight. We have our guest speaker, Jonathan Perry, here from Peterborough and Stamford NHS Trust, and he's here to talk about imaging in the diagnosis of kidney cancer. And over to you, John, if you'd like to introduce yourself.
Good evening, everybody, and welcome. Thank you for coming. Welcome to a hot and sunny Cambridge evening. I hope it's lovely where you are too. My name's John Perry, and I'm a consultant radiologist in North West Anglia NHS Foundation Trust, I work in the Peterborough City Hospital, part of that trust. I'm a radiologist, so I'm a doctor who specialises in interpretation of images. And as a supplementary, I'm an interventional radiologist, and that's a small subset of radiologists who actually use imaging chains and imaging techniques to effect change, to take biopsies or to stop kidneys bleeding or put tubes into kidneys, all sorts of things. And I do a lot of work around kidney cancer and the renal tract. I'm going to talk today on the diagnosis primarily of kidney cancer, because when I started to do the talk, I realized that covering management as well, that's really a huge topic. So we're going to talk about predominantly the diagnosis of kidney cancer. I'm going to be showing you some slides of images of kidney cancer. And there's one slide which shows me in action with a patient who is unidentifiable and who I had permission to take a photograph of the patient's back while I was working with him. And there's a small trickle of blood to be seen. So just a sort of a trigger warning, just in case you're a bit squeamish and you're having your tea. I also found it quite difficult to know what level to pitch this talk. So if there's anything that you don't understand, please ask. And if I've pitched it too low and it's you know everything about it, then I apologise for that, and perhaps we can answer any questions you might have later. So I'm going to share my screen with you now and leap into the presentation. So hopefully you can see that. So imaging in kidney cancer. First of all, I think that we're going to whip quickly through what kidney cancer is. In general terms, a tumour is a growth, and growths can be benign or malignant. And kidney cancer is one of the versions of a malignant tumour in the kidneys. And there are others. The transitional cell carcinoma can arise in the kidney, but it's a different sort of cell and the treatment is different. Lymphoma is a disease of the blood cells which can arise in the kidney, and metastases are cancers from elsewhere which have seeded to the kidney. But we're interested in renal cell carcinoma. We are Kidney Cancer UK after all, and these are all subsets of kidney cancer, the most common of which is this one down here, medullary carcinoma. But from an imaging point of view, and from my perspective, these are all the same thing. They look nearly all the same when it comes to imaging. The real problem is that one of these benign ones, the oncocytoma, it's really rare, but it also looks very, very similar on nearly all imaging modalities to a renal cell carcinoma. It's a relatively common cancer, as I'm sure you'll know. I don't really want to go into the epidemiology of kidney cancer, but it seems to be increasing. And down here you can read, as well as I can, the incidence rates for kidney cancer in the UK are highest in people aged 85 to 89. The images I'm going to show you in a moment are all from my practice, and they're all from the last 6 weeks, and nearly all of them are for people in their 60s and over. The other thing that we're finding about modern medicine is that 60% of renal cell cancers are found incidentally during scans which are being performed for other reasons. So you go along and you've got gallstones perhaps, or your doctor thinks you might have gallstones, and you have an ultrasound and it picks up a renal cell carcinoma. So that's becoming more and more frequent, and it's a real change over the past sort of 10 to 15 years of the number of renal cell carcinomas that are being diagnosed earlier, which is in general a good thing. So as a radiologist, I have some questions to answer. First of all, we've got to decide if there is a mass in the kidney. Is there a tumor in the kidney? Is it a benign or malignant mass? Then if it is malignant, what sort of malignancy is it? We've got to go to that right-hand column of the slide I showed you earlier. And if we decide that it is a renal cell carcinoma, what stage is it? And that is going to predicate the sort of treatment that is going to be available for the patient. And what imaging modalities do we have to answer those questions? Well, this is quite a long list. Ultrasound, CT, MRI, nuclear medicine, and PET and CT scans. Now, we could spend a lot of time talking about how these differ, but in essence, I'm sure that most of you know that ultrasound uses sound waves which are bounced into the patient, and the returning echoes create a map of the anatomy. A CT scan, it uses X-rays to create slices of the patient, which we scroll through to look at the anatomy and pathology. An MRI scan doesn't use X-rays, but uses the proton density of molecules within the body to make a pretty similar sort of map of the body as a CT scan, but as I say, it doesn't use ionizing radiation. MRI scans, though, are expensive and they take a long time, and a lot of patients don't find them very enjoyable. Nuclear medicine scans are when we inject people with an isotope of something which gives off a photon or some sort of energy, which we give them an injection of something which will be picked up by, say, a cancer, and then we can find out where that cancer is by where the energy is coming from. And PET-CT is a combination of nuclear medicine with CT scans. So these are a nuclear medicine scan overlaid onto a CT scan. Today, we're going to talk about almost entirely a CT scan, which is the most useful investigation of all of these in the diagnosis of renal cell carcinoma. So these are the common ones we're going to talk about. So ultrasound. I'm just going to click through that and go to here. This is an ultrasound image. And to the uninitiated, they look like polar bears in a snowstorm. But here is a kidney, this ovoid structure here, and it has got a central white area, which is the fatty tissue within the center of the kidney. And the outside of this kidney is distorted by this mass. And in this 61-year-old lady with visible hematuria, and hematuria is blood in the urine, this is a renal cell carcinoma. So this is the thing that we're all interested in. So that's what an ultrasound of a renal cell carcinoma looks like. To be honest, though, we don't spend much time looking at ultrasound, because having seen that, we're going to go ahead and get a CT scan to get much more accurate anatomical delineation of what the tumor looks like and where it is. But ultrasound really is useful for taking biopsies. And this is me with in my theatre in Peterborough. And I've got an ultrasound probe in my left hand. I've anesthetized the patient, and I'm following the needle down through the image onto the renal cell cancer, which I'm going to take a biopsy of. And this was to differentiate this particular lump from the patient's other cancer. This patient also happened to have lung cancer. So the question that was arising, was this lung cancer that had spread to the kidney, or was this a second primary cancer that the patient has developed, because the treatment pathway was going to be very different. The majority of patients with renal cell carcinoma don't come to a biopsy. We take the imaging as diagnostic, and they go to definitive treatment or first-line treatment without having a biopsy. But sometimes it is necessary to get to the biopsy with ultrasound. So CT scans. Here is a CT scan, and it could well be that same patient. So a CT scan is a cross-section of the body, and by convention we always have the right side of the patient over on this side and the left side of the patient over here. So the x-rays have whizzed around the patient in the donut, which is the CT scanner, and the computing technology turns the attenuation of each little space within that large space into a number, and the number is allocated at grayscale. So these colors indicate how much stopping power the body has at any particular point. So at this particular point, the stopping power of the vertebral, the spinous process of the vertebra here is high, and so we've shaded it white. And the stopping power of the gas here in the stomach is low, so we've shaded it black. But we could color it purple. We could turn these things anything. It's just really convention. This is the right kidney, and this is the normal kidney. And these are the blood vessels. And that's the renal vein. And there's the aorta, which is the main blood vessel traveling south. And here is the left kidney, and here is the left renal tumor. So we can see that with a large tumor, it's very easy to see where the tumor is and its extent. And of course, in the real world, I would have a series of perhaps 1,000 of these images stacked up one another, which I'm scrolling through. So I'm reading these images in a very dynamic way and reconstructing them into several different planes all at the same time. So we can get a diagnosis and a staging. This is a different patient, and this is a patient who has had their left kidney taken away. So this is what it looks like after you've had your nephrectomy for renal cell carcinoma. The slice is pretty much at the same level. This is the liver, this is the gallbladder, and we can see that there is the right kidney, and there's some of the X-ray dye which has been processed into the urine, just making that very, very white. That's the IVC, the largest vein in the abdomen, and there is the aorta again, the main blood vessel taking blood to the gut and to the legs, and there is the space where the left kidney was. You can see loops of bowel have dropped into that space now the kidney has gone. It's not always that easy. Kidney cancers start small. So here we have a CT scan which has got a normal right kidney, but on the left there are these little bobbles, and we don't know whether those are benign or malignant bobbles. So what we do is that we give the patient some X-ray dye, some iodine-based salts, which the kidney is going to take up. And in general, a malignant tumor will take up the iodine avidly. So as we give the iodine, they brighten up, and there's the kidney taking up the iodine, and this little thing has taken up the iodine as well. And to be even more sure, so we're just not relying on our interpretation, is a lump arising in a right kidney. We can ask, what is the general attenuation of this bit? And we can ask, what is the general attenuation of that bit? And we can do that by asking the computer to do some work for us. I've drawn the circles on, and it says that the value, the attenuation, is 31 of these things, which are called Hounsfield units, named after Sir Geoffrey Hounsfield, who invented CT scanner. And the Hounsfield unit of this little bit is 33, so it's very similar. So it's meaty tissue, and it's not like a cyst, it's not fluid. And then we're going to give the contrast. The kidney brightens up, and we remeasure. The kidney meat has gone up to 136, but our worrying lesion here has gone up to 92 from its pre-contrast image, which was there at 33. So it's gone up from 33 to 92. That means that this is taking up the blood that has got the iodine in. And as a general rule, that means this is quite likely to be a renal cell carcinoma. If the Hounsfield unit of a particular lesion in the kidney goes up by more than 20, we're worried. And that's how we can make a diagnosis on very small tumours within the kidneys, sort of centimetre and just sub-centimetre size. So that's where CT becomes really very, very useful indeed. Because treatment is dependent upon staging, and staging is divided into 4. And the first stage is when a cancer in the kidney is 7 centimetres or smaller. And at that stage, it is entirely possible to cut half a kidney away and take the whole tumour with it, what is an operation called a heminephrectomy, half a kidney ectomy, and leave the rest of the functioning kidney and the normal kidney alone. So that's stage 1, and it's really useful to know the size of a kidney tumour at its presentation. So this is a stage 1 renal cell carcinoma, and this kidney could be cut in 2 and half of it could be left in situ. And we want to maintain as much kidney tissue for the patient as we possibly can. Stage 2, where the cancer is larger than 7 centimetres, it becomes ever harder to take half the kidney away and get a reasonable clearance between your surgical line and the tumour itself. So 7 centimetres divides stage 1 to stage 2. Stage 3 is where the kidney cancer starts to spread, and it can spread to local lymph nodes, and it can spread in the vein and down towards the inferior vena cava. And finally, stage 4 is where the cancer has spread not only to local lymph nodes, but also to distant organs. And the most common place for kidney cancer to spread is to the lungs, but it can also spread to bones and really to anywhere, but most commonly to the lungs, where it presents with this rather typical chest X-ray appearance of what are called cannonball metastases. So this is a chest X-ray of somebody who you can see has got a central line in. That's for delivery of some chemotherapy because they're having salvage chemotherapy because they've got lots of lung metastases. So just some more images of kidney cancer. That's a normal right kidney, and this is a slice through the abnormal left kidney, which is expanded and enlarged, and you can see that the borders of the kidney are poorly defined, and there's a little bit of infiltrative rubbish in the fat around the kidney, and these are lymph nodes. So this is stage 3 kidney cancer because it's already spread to the lymph nodes there. When we give contrast, we can see the normal right kidney, and this tumour in the left kidney is all patchy and hasn't enhanced quite so well, but it certainly has enhanced. And these nodes are also brightening up because they've got cancer in them. This is the same patient, and we can see here the whole of the kidney on the left has been replaced by the kidney cancer. This is what's called a coronal slice. So we're now looking front to back through the patient, and the head is at the top of the image and the feet are towards the bottom of the image. So this is the top of the right kidney and the bottom of the right kidney, top of the left kidney and bottom of the left. Now, this patient, let me just check that this is the right patient. Yeah, this patient has an atrophic right kidney, so it has shrunk. And it's probably shrunk over the course of many, many years. And there might be many reasons, infection in childhood or a poor blood supply. But this right kidney isn't doing very much. So when this patient presented with a kidney mass, it was decided that although this might be a renal cell carcinoma, some of them grow very, very slowly. This patient was otherwise pretty sick. It was decided to watch and wait with the patient's agreement and this course of action was fine because he didn't want to be put through a big operation. And this is where we are 3 years later. So sometimes kidney cancers don't grow very fast at all. And in patients where there isn't much renal tissue to be going on with anyway, perhaps there are other serious illnesses, it's not appropriate to always take kidney cancers out. There it is again. So I think that I'm probably coming to the end of the sets of slides that I had. This is a patient who's clearly had a right nephrectomy. Ah, yes, I remember this patient. Yeah, this was from this morning's urology MDT, indeed. This patient had previously had a right nephrectomy, and the tumor turned out to be an oncocytoma. So that's a benign lesion, but it looked, to all intents and purposes, like a renal cell carcinoma, and the kidney was taken out. But under the microscope, it turned out to be an oncocytoma. And now you can just see, if you look very carefully, a new mass growing here. Now, he's already had one kidney out. It's going to be tricky to take half of this out because of the position of this. But once you've had one oncocytoma, you're likely to have another. So at the moment, we're going to watch and wait with this patient's permission to see what this thing does and if it turns out to be a malignant lesion. Because if we take both his kidneys away now, he's on for a lifetime of dialysis. There is that lesion that I was just showing you. It's rather subtle and tricky to see. This one isn't tricky to see. This is, they seem to be all left in these slides, don't they? This is an enormous left renal cell carcinoma, which has taken over the whole of the left kidney. And this is the stage 4 lesion, which has spread through the left renal vein. It's heading over towards the inferior vena cava. And in here, you can just make out that there is a ton of tumor which has spread into the inferior vena cava. Now, this makes a huge difference for the prognosis for the patient and also what treatment we can offer. The kidney cancer will probably be taken away, but that will not have dealt with this. So chemotherapy will have to be offered as well. Stage 3, anyway. So there we are. So that is a really quick romp through imaging in the diagnosis of kidney cancer. It's often straightforward. It's often easy to see a kidney cancer, but sometimes it can be very, very difficult and all the modalities can be needed. The real benefit of CT scans is it allows us to stage the stage of the disease and therefore direct the patient to exactly the right imaging, the right therapeutic regime. And not everything is always clear cut, as always in medicine. I'd like to say thank you for your attention and thank you to Kidney Cancer UK for allowing me the opportunity to present some of the images for you, and then ask you if you've got any questions you would like to ask.
Thank you so much, John. That was really informative. Thank you so much. I have a question already for you, Marsha. Knowing that the patient has an oncocytoma on the right with nephrectomy, would you not suggest to biopsy the left kidney mass at this point instead of just monitoring?
Yes, that is certainly a possibility. And if that particular lesion was more accessible, I would go for it. We talked about that with this patient this morning. There was a loop of bowel interposed between the skin surface and the kidney. The access to that lesion, which is only 1.5 centimeters big, is tricky and certainly impossible at the safest point of access because of that loop of bowel, which you obviously can't perforate with a needle. The access from a different angle goes all the way across the kidney meat and very close to the main kidney artery. So the chances of misadventure and severe bleeding, and therefore the loss of that kidney, creep up. It's a sort of a three-party discussion. I'm going to do the biopsy. Do I think it's doable? The patient's going to have the biopsy. How do they feel about it, and what is their appetite for risk? And finally, the oncologist. What are they saying about the chances of this being a renal cell carcinoma or another oncocytoma? You know, looking at all the research, it's a finely balanced question, and we might yet be going on to biopsy that.
Thank you, John. I have another question for you from Claire. Many of us have CT scans as monitoring of treatment. Can you talk through the process of how a radiologist measure the cross-section of a solid tumour? How accurate is it, and how do you know you are measuring the same X section? So
I've been showing you single slices of the whole scan. And in reality, we have this, multiple slices, which we can reconstruct into 3 planes. So to measure the volume of the tumor, we will measure its largest axis in 3 orthogonal planes, i.e. 3 right-angled planes to one another. And using a little bit of maths, then, or sometimes you getting the machine to do it for us, we will say, so what is the volume of the tumor? And if we are consistent with how we do that measurement, we can compare as we go forward through the patient's through the course of the patient's disease.
Thank you, John.
Does that make sense?
Yes. I have another question now from Richard. Is the timescale involved in receiving CT scan results typically just due to available resources, or does it also depend upon the level of complexity, i.e. do some cases need to be peer-reviewed by additional radiologists?
Yeah, there's a thorny question. It's a thorny question. In my trust, we have 3 CT scanners which are producing CT images from 0700 in the morning to 2100 hours at night, and each CT scan takes 5 minutes. So there are hundreds and hundreds of CTs being done, and there are probably, we are now 16 whole-time radiologists, I think, in Peterborough, and not all of whom are doing CTs. We just cannot report all the CT scans that are produced. So there has to be a prioritization system, and obviously with cancer and the 2-week wait rules, we go to potential cancers first. But then something else goes, to the bottom of the pile and might get farmed out to third-party reporting, which we, pay other people to do. So when, when it's going out of house, which is not ideal, but that's the way it is. We don't second read each other's scans because that just adds to the burden of the reporting that we've got to do, but we will ask colleagues, what do you think of this if we're unsure? So in general, we turn around our query cancer CTs within 2 weeks. Sometimes we don't get there, but we try as hard as we can. And I would really like to do it the same day, because obviously, these are people's lives and health, and the worry of waiting for a report, lies heavily on all of us. We are short of radiologists, we are short of resource, and I wish it were not so.
Thank you, John. Next question from Molly. My dad had a partial nephrectomy due to 2 types of different tumours, clear cell and papillary cell, which we were told it's quite rare. He was also diagnosed for benign liver hemangioma from a more recent CT. I just wonder how easy this is to see on a CT, or what factors lead to this diagnosis from CT only. Thank you.
So the diagnosis of liver hemangiomas is dependent upon the way the liver tissue handles the administration of the intravenous contrast medium. There is a particular way in which hemangiomas look. They accumulate the X-ray dye from the center out, and they sort of get whiter from the center out over the course of time, so that you can make a diagnosis of liver hemangioma on the way they accumulate and the way they wash out the X-ray dye. So we don't just do two scans, a pre and a post. We do a pre and a post and a late post to see if we can button that down. The first part of your question about having two different sorts of cancer within one kidney, yes, it's not my area of specialist expertise, but I understand that is rare. Yeah.
Thank you, John. Next question. What is your opinion on using bone scans to identify METs from RCC? What would be preferred method of imaging?
So a bone scan, for those who don't know, is where we label a phosphate molecule with something which is going to give off a bit of radiation energy. And phosphate is taken up by growing bone. And so if you have a metastasis in the bone, it tends to overproduce bone and therefore takes up the phosphate, and therefore gives off a lot of the energy which we have labeled the phosphate with. So bone scans are an excellent way of finding bony metastases from any cancers. Kidney cancer does go to the bones when it spreads, but not to the same degree, say, as prostate cancer. So prostate cancer, one might routinely have a bone scan as part of the workup of the staging of prostate cancer. But because kidney cancer goes less commonly to the bone, we would not routinely have a bone scan unless there was some clinical concern.
Thank you, John. Next question from Claire. I read a PubMed article recently that explained the frequency between scans was based on half-life science. Then how far away is radiology analysis for RCC by artificial intelligence? It's in the news now.
Yeah, it is. So I didn't quite hear the first part of that question.
This is from Claire. She read a PubMed article recently that explained the frequency between scans was based on half-life science.
Right, I know nothing. I'm going to have to plead ignorance. I haven't read that article. To be honest, half-life to me means the decay of radioisotopes, and I don't know anything about half-life science in its application to follow-up scans. It sounds very interesting, and I think that I've probably got to go and have a look at that PubMed article. The second part of the question was, what was it?
I'm just going back now.
Sorry.
Okay. How far away is radiology analysis for RCC by artificial intelligence? It's in the news now.
I think that it's not with us yet, but I'm sure it will be, and I am looking forward to it, because in general, we know that AI does really well at diagnosing cancers, or at least picking up those things where a human should have a second look. So we are using AI for the follow-up of lung lesions to see if they're looking like cancers. That's already here. But then lung cancers are small areas of solid on a background of air. So the differentiation between the tumor and what is around it is fairly large and easy to pick up. And therefore, the growth of a tumor is easy to measure and easy for a machine to get to grips with. I'm sure there will be AI. I am as yet unaware of anything which is using AI to diagnose kidney cancer. But possibly in my working life, but hopefully within my natural lifetime. I'm an enthusiast.
Thank you, John. Next question from Ingrid. Growing lung nodules, what's your advice? My scan's been brought forward. They're not sure the size quite yet for further They're not the size quite yet for further treatment. I've been diagnosed with clear cell renal cell carcinoma stage 3, grade 4, Leibovitz score 8. My left kidney was removed at Christmas, and I'm currently on pembrolizumab every 6 weeks, 5 infusions so far. What's your opinion of treatment if required for the nodules? I'm a fit 55-year-old.
Yeah, it's very difficult for me to comment. I mean, I think that, you know, without seeing the scans and, you know, comparing them with previous scans, clearly you're, you know, a long way through a tricky journey, and you have my sympathy. But without looking at the nodules, looking at the scans, it's impossible for me to say. I mean, the problem is with lungs is that we nearly all have some lung nodules. If we were ever a smoker, or if we've ever had you know, sort of other pulmonary diseases, you can get scarring in the lungs from childhood illnesses, and lung nodules are tricky. They have to be followed, and this is where AI can be very useful. But in your particular case, I'm afraid it's impossible for me to say.
Thank you, John. Next question from Lisbeth. I've had metastasis twice from RCC to the pancreas, now a third one. How common is metastasis to the pancreas in the UK? I'm watching from Norway, and my metastases are tiny and very slow growing, and I'm in good shape.
Oh, good. Well, I'm glad you're in good shape. It's a rare site for metastasis. I don't have the figures. I would need to sort of get a bit of sort of pre-warning and go and delve into the science for that. From my own anecdotal practice, and I look at I mean, hundreds of CTs of renal cell carcinoma over the course of a year, I cannot remember seeing a renal cell carcinoma metastasized to the pancreas in the last 5 years. So I think you're very unlucky to have it metastasized to the pancreas. I think it's very uncommon, but good that it's very slow growing and that you're feeling okay at the moment, and long may you remain so.
Thanks, John. Next question from Marsha. Some centres use chest X-ray when patients are on follow-up post-surgery. Is this good enough, or would you recommend to have a CT chest instead?
There's a debate. I am on the side which says that CT is more useful. The debate is partially informed by the fact that a CT scan of your chest has the ionizing radiation burden of about 50 to 125 chest X-rays, depending upon which CT scanner you're using. And therefore, you know, we know that ionizing radiation has the potential to harm, but obviously we also have to balance that about the potential to, you know, pick up metastases earlier. What are you going to do about the metastases if you do pick them up earlier? Is this going to initiate a change in treatment? Is it going to take you off a particular pathway? I believe that knowledge is power, and we should be trying to find things early, but there is a risk that we just get information for information's sake while we're using more and more ionizing radiation to do so. I think my personal view is that CT is a better follow-up tool than chest X-ray, but there is an argument.
Thanks, John. Next question from Fiona. After the CT scan, do you comment on what type of treatment will be most effective in killing the metastasis, example as in radiotherapy?
No. As a diagnostic radiologist, I spend my time describing the abnormality and diagnosing it. Is it a renal cell carcinoma? Is it a metastasis? Is it lymphoma? Is it I don't know, some other sort of pathology completely unrelated? Is it a gallstone? The oncologist takes my report and has the discussion with the patient and draws up the plan of campaign. So sometimes, the patient might say, "Do you know, I'm done. I don't want anything else," or or "I want every single stop pulled out." As a radiologist, I never see the patient apart from seeing their scan, so I don't have that conversation with them, and therefore it would be inappropriate for me to recommend treatment, even if I knew what treatment options were currently on the table.
Thank you, John. Any more questions, anyone? Another question. Please, can you talk about cryoablation therapy, please?
About?
Cryoablation therapy.
Cryoablation. So it is possible, where a tumor is small, to put a probe, a metal probe, into it using imaging techniques, and then around the tip of that probe create a ball of ice. And that ball of ice will kill the cells that are within the ball. So you use a CT scan and you place the probe into the small kidney tumor and then create the ball of ice. You can also use radiofrequency. So radiofrequency ablation is another technique which uses a similar methodology. You're putting a radiofrequency probe into the center of the tumor and then ablating with radiofrequency what is around. And you can choose the volume of the sphere, which you either freeze or you radiofrequency ablate, which is centered on the tip of your probe, which you've put in there. So with a small renal cell cancer, which is contained in the kidney, where there is no evidence of metastatic disease, you can use cryoablation or radiofrequency ablation to treat that tumor without resorting to surgery. So the sorts of tumors are the same sorts of tumors which heminephrectomy can treat, but sometimes if the tumor is sort of tricky for a heminephrectomy to get at, cryoablation is more appropriate. Cryoablation isn't offered at every center. It's certainly not offered in my trust, although it's offered, I think, nearby at Addenbrooke's. So it's not something that is rolled out to every single center yet. So if you think that how are you going to know whether your tumor is appropriately treated? It's difficult. As yet, it's not everywhere. And to be honest, I think that surgical advances have meant that it's not been the panacea which we thought it might be.
Thank you, John. I have another question from Claire. I noticed that you were doing a biopsy using ultrasound, but sometimes it's done with CT scan. What are the pros and cons of each? Is one more accurate or cost effective, perhaps?
I do biopsies using both ultrasound and CT scan, and the advantages of ultrasound are that I can angle the probe in any plane that I want. And therefore, if the kidney is sometimes well protected by the ribs, and therefore I can angle the probe between the ribs and make sure that my needle is going to the tumor. With a CT scan, the CT scan just takes a slice sort of 90 degrees to the patient's long axis, and you have to be using your needle in that plane. And sometimes it's very difficult to access the thing you're trying to biopsy using CT scan. So the advantage of ultrasound is that you're much more flexible. The disadvantages is that it can be very difficult to see the needle which you're tracking with ultrasound, and sometimes, depending on the size of the patient, it can be really difficult to see the target that you're trying to biopsy, whereas CT gives you a much easier visualization of the target. So when I am asked to do a biopsy, those are the sorts of considerations that I'm going to make before I choose which modality I'm going to use. And I won't be told by the urologist which modality to use. I'm doing the biopsy, so I make the choice, and then we'll work through that with the patient.
Thanks, John. Another question: is CT biopsy done under local anaesthetic as ultrasound biopsy?
In my hands, everything's done under local. It's very rare that we need general anaesthetic to do biopsies of the kidney. Local anaesthetic, really excellent at getting rid of the sensations of pain and light touch from the skin and the track down to the kidney. So long as the patient is sort of relaxed and you've got a good rapport with the patient, it's very straightforward. The kidney moves as you breathe. It's underneath the diaphragm, and as the diaphragm flattens, when you breathe in and out, the kidney moves. And so you have to have a degree of cooperation from the kidney, so that when you fire the biopsy needle off, you've got the needle pointing at the bit that you're trying to get, and the patient doesn't suddenly take a gasp in and move the kidney. So,
well, thank you so much, Jonathan.
a pleasure. Absolute
and thank
pleasure.
you for
Good
coming,
luck.
everyone. Thank you. Bye.